Hi, good afternoon. Coming from Austin, Texas at the Combined Ophthalmic Symposium, we're pleased to have Dr. Nate Radcliffe with us today. Good afternoon, Nate. Thanks for being in with us.
It's great to be here.
Nate, we always have such great discussions about glaucoma on the program, and I think today we'd like to focus on surgical treatment of glaucoma rather than medical treatment, which we've spoke about quite a bit before. So let's get right into it. I'm kind of curious from your perspective about where surgery comes into play when you're planning a treatment paradigm for your patients.
Well, I think with traditional glaucoma surgery, trabs and tubes, the answer to that question was when a patient is pretty much facing blindness, and we finally decide that their risk of going blind from glaucoma is higher than from some of our more invasive surgeries. With MiGs, we can now lower that threshold because we have safer procedures to offer patients, so we can start to factor in, your quality of life isn't as good as it could be, and I've got a safe alternative to get you off some drops, maybe make you more comfortable. So it's rapidly evolving.
So it sounds like with the advent of MiGs, you're able to intervene at an earlier disease stage because you have more confidence in lower side effects. Is that what I'm hearing?
Yep, absolutely. And I'll give you there are two different patterns. One is what you would call the sort of standalone MiGs that really were traditionally evolved with cataract surgery. This would include, canaloplasty, goniotomy, or a trabecular bypass stent. Very safe, but the efficacy there is modest. So we pick and choose, and for some surgeons it's tough to get someone to the OR for a modestly efficacious procedure, even if it's exceptionally safe. With transconjunctival MiGs, you really have a neat kind of new opportunity because you can get patients with a pressure 12 off drops with the subconj MiGs, such as right now what we have is a XEN 45 gel stent. And you can do it in a very safe way, something that is, in my mind, categorically different than, say, a trab or a tube, which have much higher safety risks.
Well, I'm glad you brought up the XEN. Can you explain for us how that differs from some of the other MiGs technology that we've seen on the market?
Sure. There are three categories of MiGs. There's the trabecular MiGs. These include iStent, again, goniotomy, canaloplasty, the Hydrus. And the problem there is episcleral venous pressure is going to stop you maybe in the mid-teens, and you can get pressures down nicely from the mid-20s to the mid-teens, but you're sort of stopped there. If you look at the transconjunctival MiGs, so the XEN, you can get someone from 40 to 10, if you get a good bleb formation. Now, you have to tend to that bleb carefully and thoughtfully, and you need to use antifibrosis to get a nice-looking bleb. But it can be done, and because the XEN is a 45 micron internal lumen, limits flow, so you don't see profound hypotony, flat anterior chambers, any of those risky things. So you've got a new model where you can kind of expand your offerings to patients to tailor a little bit better to their needs.
So it sounds like to me that the XEN, which you just described, is perhaps giving you results similar to what you might expect with an old-fashioned trabeculectomy. Is that right?
Yeah, it's in my case it is. In fact, I stopped doing trabeculectomy about 10 years ago because I had concerns about whether the safety issues were something I wanted to offer to my patients. I've gotten back into this type of filtration surgery, and I've even played around with the XEN technique a little bit. XEN can be placed three different ways. This is the on-label ab interno approach, where you come from the inside. You can place it almost like I did for the XPRESS surgery through a conjunctival peritomy, and that's a nice way. You can apply minomycin to the sclera directly in that technique, or you can do the transconjunctival XEN, which is probably from a efficiency standpoint a remarkably efficient procedure. And for some doctors in the right practice can be, a very nice, elegant, slick, safe way to address urgent glaucoma problems.
That's a great point, and that kind of transitions us into the next point, which is to see who is the right surgeon to be performing these types of procedures. Does it necessarily have to be a glaucoma fellowship trained surgeon, or can any cataract surgeon be trained in these techniques?
Yeah, so I think the one thing you have to have is an interest, and that's it. Anyone who can do cataract surgery is incredibly talented surgically and can do all the procedural aspects. if I look at my glaucoma fellowship, it was a lot of dealing with serious complications from trabeculectomy and occasionally from tubes. I don't think you need necessarily to have that toolkit to do XEN because, again, the safety is there. But you do need the willingness. You need to learn a little bit about how to minimize fibrosis, needle a bleb from time to time. But if you have the patience, and I would argue a busy comprehensive ophthalmologist who's been following patients for a long time, those patients probably want to stay with that doctor. Maybe have one procedure with that doctor before they get shipped off to the glaucoma specialist. And so in my mind, if a comprehensive ophthalmologist who refers glaucoma to me wants to place a XEN first, keep the patient in their practice, and refer out if there's a problem, for me that's a good relationship. And I think it benefits patients to have the doctor they've known for many years doing these procedures.
That's a really good point, Nate. And I wonder if, as a last point here, we can discuss if surgeons are not currently doing MiGs or currently trained in MiGs, what are some initial steps that they can take to get involved?
Right. So, this is a great point, and, everything that I'm doing today I learned after my fellowship was over. So, how did I do that? Well, you have great resources. You have all the magazines. iWorld's a great resource. YouTube is a good place to go see videos, but then talking to the rep is part of it. You can talk to a colleague, and I do have colleagues who will join me and sort of sit in on some surgeries. But reps ultimately have training courses, and this is all very streamlined in 2019, 2020, with formal programs you get certified. And then they come in for your first cases, and so for example, for XEN, you'll typically do 5 cases, follow those patients for a month, then do another 5, and sort of modify your technique and your approach as you gain experience, but again, with support from the company. And that will include access to peers who place these surgeries, so that if you do hit a bump in the road, you'll have someone you can reach out to.
Well, Nate, this has been a great discussion for us this afternoon about XEN and how MIGS technology plays a role in your practice. Thanks so much for sharing your expertise.
Thanks, John.